Hello and welcome. In this section, we will focus on cold agglutinin. We'll discuss how to manage patients with cold agglutinin disease in the emergency department using a patient case scenario as an example. I am Joseph Kiss, the Medical Director of Clinical Apheresis and Blood Services at Vitalant, and I'm also a Professor of Medicine at the University of Pittsburgh in Pittsburgh, Pennsylvania. Let's briefly go over the learning objectives for our activity today. At completion, you should be able to identify cold agglutinin disease, associated symptoms and complications, and implement best practices to provide tailored approaches for management in the emergency department. We also aim to advance your knowledge regarding the efficacy and safety of current and emerging therapies. This will hopefully enable you to implement personalized, evidence-based approaches to managing benign rare blood disorders in the emergency department setting. I'm going to begin by describing cold agglutinin. I want to make the distinction at the outset that cold agglutinins are different from something else that you may be familiar with, which are cryoglobulins. Sometimes these are confused. Cryoglobulins really have nothing to do with binding to red blood cells, whereas cold agglutinins avidly bind to red blood cells and cause anemia and other problems. This slide, which shows a immune B cell, a B lymphocyte, that elaborates a cold agglutinin, shows the sequence of events that may occur if patients form a cold agglutinin. In such patients, B cells produce immunoglobulin M antibodies. These are cold agglutinins. By the way, they're called cold agglutinins because they bind optimally or maximally in cold temperatures such as 4 degrees and can cause clinical problems therefrom. These B cells can be and are usually monoclonal in terms of their clonally expanded B cells that make these antibodies. But in some patients, triggered by autoimmune disease or by infections, these can be polyclonal, and we'll make that distinction as we go along in my talk. At any rate, these IgM antibodies, which are very large antibodies, bind to red blood cells. They bind specifically to polysaccharide antigen, and we'll talk more about these as well. This can then actively and efficiently trigger the first component of complement to be activated, so-called C1q, which then sets in process a series of events, essentially a domino effect, that can cause clinical features in clinical disease. So you see the C1 here at the top of this cascade. This activated C1 can then progress through C3, and C3 on the red blood cell, generally it's C3b, a subcomponent of C3, and then be picked up by receptors, largely in the liver, but also in other organs, and essentially leading to extravascular hemolysis. If the complement sequence or the antibodies that the IgMs are part of are particularly strong, high titer, or particularly avidly binding, one can get activation of C5 all the way down and get C5b through 9, which punches holes in the red cell membrane depicted in the lower side of the frame here. And you could see a patient with intravascular hemolysis. This, however, only occurs in a minority of cases where people may have cold agglutinin. We want to talk a little bit about the classification. The one that we will talk about first is primary cold agglutinin disease, which is associated with a low-grade clonal lymphoproliferative syndrome. Also important for the emergency department setting, secondary cold agglutinin syndrome can occur, and this can be developed in the setting of overt malignancy, such as a patient who might have chronic lymphocytic leukemia or lymphoma, or may develop due to an underlying infection, for example, mycoplasma pneumonia and infectious mononucleosis. These are generally lower titer and temporary clinical events. I want to go on to the clinical features, and patients with cold agglutinins can present certainly with symptoms of anemia, and we're all familiar with these symptoms: shortness of breath or dyspnea, fatigue, jaundice, dark urine, which needs to be distinguished, of course, from concentrated urine or in hematuria by looking at the urinalysis, looking for red cells versus hemoglobin pigment in the urine. But the cardinal feature or specific feature of patients with cold agglutinin is the development of acral cyanosis, which is a bluish or grayish discoloration of the skin in the peripheral areas of the body, namely the fingers, the tip of the nose, the earlobes, and the toes. Rarely the sludging that occurs in the capillaries can lead to such ischemia as to produce ulcers and even gangrene. Epidemiologically, cold agglutinin disease in most cases presents in older age individuals. The majority of patients are over 60. The average in studies varies, but a typical age would be 67 or so. There's a slight female predominance. Cold agglutinin syndrome can present in younger ages, including in pediatrics. And these individuals often have an underlying infection or autoimmune disorder. They're a younger epidemiologic segment. Moving on now to discuss the pathophysiology, why people get acral cyanosis. That's depicted here. I'm showing here a red blood cell depicted in red and an IgM antibody depicted in green. These IgM antibodies have specificity for polysaccharide antigens on the red cell. Most of them bind to what we call big I, and there are some of them that preferentially bind to little I antigen. These are essentially blood bank terms, and then can be sorted out in the blood bank. At any rate, in the acral portions of the body, which can reach the lower temperatures that you see here is 28 to 32 degrees centigrade, there is binding of the IgM to the red blood cells in the capillaries, creating sludging, creating ischemia and deoxygenation of tissues, leading to that darkened color I mentioned earlier. This also fixes complement. And then when these red cell IgM complexes rewarm as they enter the core body temperature, going to the left here at 37 degrees, the antibody comes off, it dissociates, leaving a complement-coated red blood cell. The complement-coated red blood cell then are destroyed, creating a hemolytic anemia, again, largely in the hepatic RE system, but they also can be detected with special reagents by the direct Coombs test. We can detect this with anti-C3b or C3d that coats the red blood cell. The amount of hemolysis is variable, but in most cases, there's a mild to a moderate anemia. In some cases, particularly the acute presentations, you can, again, get intravascular hemolysis. Now, how do we detect hemolysis? First of all, we would have a patient that would have anemia on the CBC, but we look for evidence of excessive destruction of red blood cells. And this can be manifest by an elevated total and indirect bilirubin, an increased lactate dehydrogenase or LDH. We can get a very low or undetectable haptoglobin level that binds to the hemoglobin, and we can see an abnormal blood smear that will come back. Again, if it is particularly severe, one can see hemoglobinuria, and if the blood bank or another laboratory spins down a specimen of the patient's blood, one can actually see the hemoglobin pigment in the plasma, oftentimes misjudged and saying, well, it was a bad stick, it was a poor sample that was obtained from the patient. However, this may truly be what is happening in the patient's blood, and his hemoglobin is released in the red cells and then being cleared in the kidneys, excreted in the urine as hemoglobinuria. If, as part of the evaluation for anemia, determine the reticulocyte count, these should be increased, reflecting compensatory increase in red cell production if the patient has normal hematologic system. So the first step is to diagnose or provide evidence of hemolysis. Now, cold agglutinins can produce a very unique thing in the blood smear, as you see here on the next slide. That is, cold agglutinins, being IgM, can directly clump these red cells. And I showed you the mechanism earlier. They can basically bridge across the red cells and create this clumping phenomenon. This also happens macroscopically in blood specimens, leading to clumping, which can be confused with clotting if one is not savvy to that possibility. And it's not uncommon for the comment to come back, we couldn't get the patient because every time we drew the patient, the blood clotted. Well, fortunately, there's a simple procedure that you can use to discriminate between clotting and clumping, and that is just to rewarm the tubes. That can be done in warm water. It can be done if you have anything like a heel warmer available. And it can also be done just by rolling the tubes in your hands, and it's a very effective way to demonstrate that this is clumping and not clotting of the sample. As I mentioned, this can lead to confusing results in blood testing. The next slide describes we are taught that the hematocrit generally is about 3 times the hemoglobin content. In cold agglutinin disease, because of this clumping phenomenon, the red cell count is undercounted by the hematology analyzer. And the product of the two in the analyzer, the RBC count times the MCV, is what the machine uses to derive the hematocrit number. This leads to an artifactually low hematocrit compared to the hemoglobin and can be confusing. It is also true that the MCV is increased, and that's also an artifact because red cell doublets can be counted as single red cells, which use the mean corpuscular volume measurement, which is measured. But in general, the very low RBC count wins out, and one gets a very low hematocrit compared to what the hemoglobin result is. If this occurs, just remember that the hemoglobin result is reliable because this is a directly measured value. It's not a derived value. In addition, I told you that laboratories may report specimen difficulties, and the blood bank may report blood type or antibody screen test difficulties. These can be recognized and alleviated in the blood bank, and we frequently use a technique called pre-warming, where we take the tubes, warm them, and get accurate results. This then gives us a direction that all tubes drawn from such patients should be pre-warmed 38 to 40 degrees and their specimen temperature maintained while they're transported to the laboratory without delay. Some larger hospitals may have what's called a heat block, which can be supplied, and the tubes can be pre-incubated here, and then when the patient's drawn, the tubes can be put back in the heat block and sent to the blood bank to maintain the temperature. As I mentioned, if you have a pediatrics facility, a heel warmer can also do the trick. The next slide shows us a diagnostic test result in patients with cold agglutinin. In the blood bank, if one orders a direct antiglobulin or Coombs test, first screens using a polyspecific screening reagent. Polyspecific just means that the reagent has both anti-IgG and anti-C3 reagents mixed in. If this is negative, the screen is negative, and that's a negative test. However, if that's positive, the blood bank then uses anti-IgG and anti-C3 monospecific reagent. And the finding in cold agglutinin patients, as depicted in the panel on the left, is that the complement on the red cells is predominantly positive. That is, it'll be strongly positive, 3 or 4 plus. The IgG should be and is usually negative. However, it's not unusual to see a weak or 1 plus IgG, and this should be recognized that that's possible in this setting. Now, the cold agglutinins, their characteristics can also reflect their underlying cause or etiology. As I mentioned, most of these are monoclonal proteins, and because most cold agglutinin disease comes from patients with lymphoproliferative disorders or frank hematologic disease such as chronic lymphocytic leukemia. In a small proportion, maybe 20% or 25%, again, depending upon whether your hospital is pediatric or adult or some mix, one may see a polyclonal antibody, and this is commonly seen in viral or bacterial infections, or could be due to autoimmune disease such as systemic lupus erythematosus. Therefore, a serum protein electrophoresis is very useful to distinguish these etiologies to tell us whether it's a monoclonal or a polyclonal process. The next slide then summarizes the essence of diagnosis for cold agglutinin-related disease, and that is, first of all, establishing the presence of hemolysis, and we talked about the laboratory testing that tells us hemolysis is going on and is the cause of the anemia. We then find a positive direct antiglobulin or Coombs test for C3b or C3d. Some labs use an anti-C3b, some an anti-C3d. At any rate, it's a C3 endpoint for the assay. And then the titer is important for diagnosis. Laboratories differ slightly in this respect, but most laboratories consider a cold agglutinin titer at 4 degrees, less than a titer of 64, to be their normal reference threshold. Anything higher than that would be considered abnormal and possibly pathologic. But most people with cold agglutinin disorders have very high titers, and there's just simply no question. If you get a titer of 1 to 1,024, and I've seen patients as high as 1 to 20,000 or even higher. Now, the factors affecting hemolysis also reflect whether it's clinically significant. One can have cold agglutinins and not have particularly significant clinical disease. The titer, again, is usually high, and that will help to sort out clinically important from non-important, but it's not in and of itself diagnostic. The real significance of cold agglutinin are if they cause precipitation or agglutination of the red blood cells at least 28 to 30 degrees centigrade, because the body doesn't normally get below that temperature. And so the laboratory, namely the blood bank usually, can do what's called a thermal amplitude test. And I don't need to go into detail here, but they basically take and, again, use a sample that has been collected and maintained in a warm environment. They also, and I should mention that this is true. Whenever the red cells and the patient's serum or plasma is together, the tube should be warm. Once the plasma or serum is separated from the red cells, one can do different things with it. One does not need to keep it at that warm temperature because the adsorption that can occur with the red cells is taken away. But the blood bank can do a series of incubations and prove whether the antibody is present or causing agglutination at 30 degrees or higher. So this would be considered clinically significant. If it's at room temperature, 20 to 24 or colder, it's generally not considered clinically significant, and these are generally lower titer antibodies. I just wanted to briefly mention, again, because you're in the emergency department and you do see infectious disease, that this is an important presentation, and the so-called infection or autoimmune secondary cold agglutinin syndromes usually occur in the immune recovery phase, so that the acral cyanosis and the anemia occurs usually 2 to 3 weeks after the onset of the illness or even after recovery of the illness. The good news is the anemia is generally self-limited, and these patients are generally followed with resolution. And when we check their antibody, they generally tend to be polyclonal and low-titer antibodies. However, serious and even intravascular hemolysis may occur. This brings us to how we treat cold agglutinin hemolytic anemia. The first principle is avoidance of cold and maintaining a warm ambient temperature. For this reason, the cold agglutinin disorders do typically get worse in the winter months in northern climate. However, even in the summer, patients with cold agglutinin disease have symptoms when they go into air-conditioned environments. That transition from a very warm to a cool or a colder environment can be very critical in terms of precipitating attacks. And patients often learn this on their own, an avoidance of cold transition. An important principle in terms of red blood cell transfusion. Now, if transfusion is indicated, and many patients it isn't, but if it's indicated, or if one needs to administer IV solution, very important to use a blood warmer to make sure that the solution entering the patient's body is at body temperature or close to it. This will avoid problems. You are probably accustomed in the emergency department to giving red cells at a very fast rate. But in the case of cold agglutinin disease or suspected cold agglutinin disease, you want to transfuse slowly. So what does that mean? Well, typically if you're transfusing a unit of red cells over 1 to 2 hours, in patients you suspect have cold agglutinin disease where you have made the determination that transfusion is necessary, you want to go more slowly, maybe over 2 to 3 hours. That's because the red cells in a unit of blood have not been sensitized by the antibodies, and the patient's body has kind of already reached a steady state between the antibody and complement. So you're giving essentially fresh antigenic material there that if their titer is high will be instantly bound with that can fix complement, and that can actually precipitate an episode of worsening hemolysis. If this were to happen, or if the patient were particularly severe, one can consider a technique called plasma exchange, which would result in acute removal of the IgM antibody. These antibodies are easily removed by plasma exchange, and in fact, this has been classified by the American Society for Apheresis as a category 2 of their essentially 1 through 4 category system, 1 being the highest evidence-based category and 4 being the least. It's a fairly effective category. They've deemed this to be effective in severe disease. Now, what about chronic cold agglutinin disease? Again, the cardinal principle is to avoid cold, maintain a warm ambient temperature, but this is generally the purview of hematologists now to treat the disease as primary therapy. Immunotherapy, such as anti-CD20 monoclonal antibodies, rituximab, have been typically used with about a 50 to 60% overall, maybe slightly higher response rate. Bortezomib, the proteasome inhibitor that targets plasma cells, has also been used effectively. In the old days, before we had these, we used alkylating agents, oral alkylating agents or intravenous. And in current day, combinations of chemotherapy such as bendamustine plus rituximab have been very successful in knocking down these clones and producing clinical remission. I want to emphasize that there are currently no FDA-approved indications. There's also hope on the horizon here with investigational drugs, again, not FDA-approved, and I'm going to mention 2 very briefly. The first is sutimlimab, which is a monoclonal antibody targeted to inhibit complement C1. This is in clinical trials. There's been a very important small trial of 10 patients published in Blood recently that showed significant responses in 7 of 10 patients with improvement of hemoglobin by an average of about 2 grams Many patients will improve over 4 grams in their anemia and reducing the need for blood transfusions and improving their hemolysis parameters. The nice thing about this drug is it seems to act very quickly, and there was a very fast clinical evidence or laboratory evidence of improvement in the indirect bilirubin and LDH measures of hemolysis with no serious adverse events reported. Second drug also in clinical trials is called APL2. This is a synthetic peptide that targets at the C3 component of complement. This has also been shown to reduce hemolysis and increase hemoglobin. I would also just mention parenthetically that eculizumab, an anti-complement C5 inhibitor, has also been used to some promising effect, but these are all unapproved therapies. I'd like to now summarize managing suspected cold agglutinin disease in the emergency department. First of all is making the diagnosis. Acrocyanosis is a very typical. Most patients will have this, so look for this finding and recognize it. One should look for laboratory evidence, of course, of anemia and specifically hemolytic anemia, and check the Coombs test. In terms of blood sampling, remember that clumping does not equal clotting, and one can rewarm samples and pre-warm samples to get good blood samples from these patients. You need to keep the ambient temperature and the patient and blood samples warm until they are appropriately handled in the laboratory, and to transfuse judiciously, and that means slowly, using a blood warmer if one needs to transfuse. And I would invite you to now take a look at a patient scenario in the emergency department.
Hi, Amy. I'm Dr. Sini. Nice to meet you.
Nice to meet you.
What brings you to the emergency department today?
I'm feeling weak and cold in my hands and my feet, especially when I go outside. I also have a mild fever and a cough. I've been diagnosed with cold agglutinin disease, and my hematologist told me I'm stable.
Okay. I do notice that you have a little bit of purple discoloration to your fingers and to your nose. How long have you had that?
This started last night, but it's becoming worse.
Has this happened to you before?
No, this is the first time.
Have you noticed any color changes to your urine?
My urine is much darker than normal.
Okay. You also have a slight yellow tinge to your eyes. Have you noticed that?
I did not notice that.
Okay. Any other medical problems I should know about?
No, I'm healthy.
How long have you been coughing?
I've been coughing for the past couple of weeks.
Are you taking any medicines for that cough?
No, I hope it was going away.
Okay. Any shortness of breath?
Yes, I noticed it is becoming worse over the past week. Today, I could barely catch my breath walking in here.
Okay. When were you first diagnosed with cold agglutinin disease?
2 years ago.
Do you follow with a hematologist regularly?
Yes.
Okay. So this is what we're going to do. First, we're going to cover you with a warm blanket to try to improve your symptoms. We're also going to get some lab tests and a chest x-ray since you've had that cough for a couple weeks now.
Okay.
Okay, let's take a look at those hands. How are you feeling?
I'm feeling a little better.
Good. I think they do look a little bit better. So your labs resulted and your hemoglobin is low today. So we're going to have to give you a blood transfusion. We're also going to give you some IV fluids to rehydrate you. We're going to put both of those on a warmer to make sure that we don't make your symptoms any worse. Additionally, your chest x-ray did show a community-acquired pneumonia that we're going to treat with antibiotics.
Okay, that explains it.
The blood bank did tell me that they confirmed cold agglutinins in your sample, so it's going to be really important to follow up with your hematologist to talk about any further therapies that might be helpful for you. I think it's going to be okay for you to go home after your blood transfusion, but it's going to be really important for you to avoid cold exposure as much as possible and to finish the course of antibiotics I'm prescribing so we make sure that that pneumonia is treated.
Okay, I'll do that.
Here are some key takeaways for the management of cold agglutinin disease in the emergency department. Evaluate for the severity of symptoms and any precipitating factor, such as exposure to colder ambient temperatures, acute illness, autoimmune disorder, or a lymphoproliferative disorder. Typical symptoms include acrocyanosis, Raynaud phenomenon, cutaneous ulceration, or pain or discomfort on swallowing cold food or liquids. Be sure to keep the patient warm and use a blood warmer for the transport of any blood we're sending to the laboratory or any infusions that you might give the patient. The treatment is generally to address the underlying cause and avoid cold temperatures and provide a blood transfusion if indicated. Evaluate for and manage any complications, which in this case was pneumonia, for which we did a chest x-ray and provided antibiotics. On discharge, Be sure to provide instructions on how to avoid cold exposure and emphasize the importance of hematologist follow-up.
We can now translate these into SMART goals, and I hope that my talk today will enable you to promptly identify or at least suspect cold agglutinin disease in the emergency department and provide appropriate initial management. I hope that you will be able to recognize the pathophysiology of cold agglutinin disease in terms of what these antibodies do to blood samples and how they can confuse the picture of blood samples, and you can remedy that by appropriate collection and maintaining those blood samples, and that you can effectively transfuse patients and safely transfuse patients if they need to be transfused. Really, just like